everyone. Thank you so much for joining the Sanford Institute's first Spring Speaker Series session of the year. Before we get started, I wanted to let you know that the Speaker Series sessions will occur almost every month this year, so be sure to stay tuned on Eventbrite when the summer series is open for signups. Now, back to today's speaker, we have Dr. Ryan Moran, who will be presenting on burden and burnout, non-face-to-face primary care. Dr. Moran is a clinical professor in the Department of Medicine and the School of Public Health at UC San Diego. He cares for adults across the full spectrum of health and primary care. Within UCSD, his focus on measurement science and quality improvement includes active collaboration with the Population Health Service Organization to optimize clinical processes and address gaps in care. His research and clinical innovation interests include improving measurement science in health service settings with a focus on clinician well-being and burnout, enabling both physicians and patients to perform at their highest capacity and achieve optimal clinical and personal outcomes. Please feel free to submit any questions through the Zoom chat function during the presentation, but note that these questions will only be answered at the very end. If you want your questions to be anonymous, you can privately message me through Zoom and I can ask the question on your behalf. Without further ado, please welcome Dr. Ryan Moran.
Well, thank you. Thank you very much, Cindy, and thank you everyone for the time this I guess afternoon. Really appreciate it, and really appreciate the opportunity to share some of the early results for an ongoing project, but certainly the first phase of a pilot for something that's near and dear to me, which is the challenges that primary care sometimes have in taking care of the patients that we care for. And one of those, of course, is the electronic medical record and health record burden. So I'm going to talk a little bit about that and what that means and contextualize it a little bit. But first, disclosures. I have no personal financial disclosures, and certainly while I have my biases regarding this topic, all of these have been absolutely independently validated and checked to make sure that the results are as appropriate as I am presenting today. And I wouldn't be able to do this if it weren't for the generous support from the Denny Sanford Institute for Empathy and Compassion to fund this pilot back in 2023. The first is I want to just lay a little bit of context for the outline. Is I'm going to go over the background for why I'm talking about this topic, why this topic was important to me as well as my division to really support, and why it's important, hopefully, to convince you that it is important, but also give a little bit of context about locally, why does this really matter? And then I'll go into the methods of what we did and then talk about what we found and what the conclusions were drawn, and then blend a little bit into what we're doing right now to make use of some of these pilot findings to really organizationally move the dial to better monitor and manage, and then have some time for some questions. The first thing I really want to settle on is the fact that physician well-being is not just important for physicians and healthcare providers at large, but it's really important because it's well recognized in the literature that physician well-being and lack of burnout is associated with a more positive patient experience, reduced medical errors and satisfactions. The corollary to that is physician burnout is associated with the opposite of that. So worsened patient experience, more medical errors, and decreased job satisfaction, increased job turnover, as well as early retirements, which indirectly as well as directly also impacts patient care. And that burnout rates continue to be substantial in the United States. And what you can see on the right here are two different independent ways of assessing measures of burnout, one from the American Medical Association on the top and one from Medscape on the bottom, which assess annually, for Medscape at least annually, for measures of burnout. And a couple things I want to highlight here is that first, it's a sizable minority in general across the years. And the other one is that it's a little sticky, it is still volatile. And that's important because that means it's able to be influenced, it's able to be changed. And there are some external, but there are some internal or organizational contributions to this. One of the major ones is the time that's spent outside of direct patient care. This has been shown in the literature, as well as in local contexts, that when patients are spending a lot more time managing patients, not directly caring for a patient when they're in front of them, it can drive burnout. The time burden in and of itself is a driver. And this really, I think, stems from several different factors that have been shown in the literature. One is that generally this work is unpaid, it's uncompensated, and it's underappreciated. it's considered invisible work, something that happens on the back end, that when it's not there, it's noticeable, but when it's there, it's kind of commonplace and accepted. And so this non-face-to-face work has grown over the years, which hopefully I'll convince you of by taking you a little bit of a historical tour on some really important legislation, as well as the evolution of technology for much of what we I think take for granted today in the electronic health records. The earliest documentation of any sort of predecessor to electronic medical systems and medical or health systems date back into the 60s with really early pioneering. The first modern system that would be considered generally a medical record was pioneered in the Midwest in the early 1970s. This really kind of laid a lot of the foundation that there was a relatively rapid early expansion for electronic documentation and computing technology throughout the 80s and into the early and mid 90s. And along this time, E&M or evaluation and management coding, which is often how clinicians document their specific billing, began integrated into the electronic medical record. In the 2000s, EMR adoption, though, really was still quite limited. There was a lot of challenges with it. They were expensive, they were cumbersome, and they were also very niche. So there was very little interusability, and it really was highlighted with nationally fragmentation of care. And at the time, it was estimated that somewhere between only 12 and 18% of clinics and academic medical centers had what we would consider a usable electronic medical record. This really changed very rapidly in the late 2000s and early 2010s, really spearheaded by the Health Information Technology for Economic and Clinical Health Act, or the HITECH Act, if anyone's heard of this. This introduced the concept of meaningful use, which perhaps that buzz term has been circulated in some other contexts, but it really started to emphasize the importance of quality, reducing errors, and interusability and interoperability of health systems. And this really spearheaded and accelerated the national EMR and EHR adoption. And I think it's important just for a moment to highlight the distinction between those terms. EMR is, or a medical record, is really a term that's one encounter, one patient that helps to complete documentation and sometimes billing, whereas electronic health record is really a more comprehensive longitudinal assessment and understanding of someone's health over the course of time, and usually in several contexts. It's often, especially in today's time, able to pull in real-time information from different health settings at the point of care delivery, and sometimes not at the point of care delivery, hence non-face-to-face care. Through the modern realm, 2010s to the present, these electronic health record systems have increasingly become interoperable, and they've increasingly supported and endorsed the use of patient portals and registries and mobile integration and expanded documentation. And in the late 2010s rather, there was a big evolution of the evaluation and management standards as well. And all of this really coincided with more and more time being spent on the interdependence, both for patients as well as healthcare providers in the medical record. Now, locally, some important context to keep in mind is in 2020, UC San Diego Health had a very massive shift in how care was delivered in primary care context. It's called the primary care redesign, which was really an attempt to integrate across the different primary care settings standards of how reimbursement for physicians is managed, but then also how panels, when I say panels, I mean how many patients are cared for a specific healthcare provider is managed. So it really helped to push in an adoption of understanding quality goals in value-based care, VBC, buzz terms. But the reality is that at the time, there was really no best practices for measuring, monitoring, or managing what that really meant in terms of quality and value-based care, and also in terms of the time that is spent in that volume-based care. In 2021, the CARES Act passed. If anyone has heard of that or remembers that, this was a really important piece of legislation that originally was enacted in 2016 with a 5-year phase and went live in 2021, which largely mandated the real-time access of patients to have their medical records, which meant that overnight patients were able to access their labs, imaging studies, and notes almost before the physician was able to see them and review them. This studies have found coincided with a greater than 50% increase in patient-initiated portal messaging. And right off the bat from passage of this piece of legislation, it was estimated there was conservatively between an 8 and 10% total jump in time that physicians were spending in the medical record alone. So a really important piece of legislation. Now, I'm going to take you a little bit back more locally again, back in 2023. One of the main reasons that this project came to be is because in 2021, which you can see here for the first time, the survey, which I'll talk a little bit about, was issued, which was after the primary care redesign. The organizationally wide, there was a lot of change management and change in general. And Chartis Health was contracted out to better understand how burnout was across the system. And in 2021, there were several local issues that were seen within my division. And one of them was non-face-to-face time. And it became very apparent that there was a lot of time being spent on the medical record. And my clinical services chief and division chair was a very stern advocate of making sure that this was addressed because of the concern for some local burnout that we were having, as well as turnover within my division. And so you can see the N of 35 for the original survey and then 32. So a delta of 3 in a couple of years, which I want you to pay attention to in a couple more slides. But for whatever it's worth, one of the most endorsed measures, which I'll talk about a little bit later, is a measure called pajama time, which I'll define again in a couple slides. It was very it's important to my leadership to decrease pajama time. Now, I thought it was paternalistic to focus on a specific earmarked part of time and focus on that instead of the total amount of time, since people work in different ways. And so we had a really productive conversation where it really became apparent we didn't really know the best way of measuring how much time was being spent. And so that really helped to stimulate what this project became to be. But in 2023, what you can see is from the 32 responses, the average amount of hours that physicians in my division worked was reported to be 62 hours. It was highlighted by Chartis as an area to improve, and 66% were burned out. Importantly, at the time, though, and again, there's a lot on this slide, 69% of my division said they were actually satisfied with the EHR. Despite that, Chartis Health said EMR satisfaction is a key focus to improve. So this really helped to issue a lot of efforts underway at the organization as well as in my division. Now, fast forward to 2024, so a year later, you can see the N drops by 9, so the end of 23 now. So there's less engagement and some departures. The total number of hours dropped to 57. You can interpret whether or not that was from people leaving or whether or not there was improvement. But what's really important, though, is now only 45% were satisfied with the EHR. And Chartis changed it instead of saying a focus to improve to concerning, actually. So it's not quite as bad, even though the satisfaction dropped by 20 percentage points. Now, fast forward to the most recent one, which was released relatively recent. The average number of hours is 57.8, and there's no more EHR satisfaction even being asked. Instead, really importantly, there's a movement away to say we really want to understand the processes within the EHR instead of the EHR itself. So how are physicians being enabled to work at the top of their license? So this is the most recent version, and this is really topical to my talk because the use of EHRs are really critical to patient care. No one's going to ever debate that, but they can contribute to burnout. And Obviously, I think many people in this room have had an experience where they've spoken with a healthcare provider and they're staring at a computer the whole time. And that's not exactly what patients want. And rest assured, that's not generally what physicians want either. And the reality is that that time spent helps to drive decreased job satisfaction and burnout. Again, when time is spent outside of direct patient care, it's been a focus area because this has been shown as to be the driver, especially because it is not directly compensated either in an RVU model or above scheduled hours in a salary model, which is generally what salary is based upon. So it really continues to incentivize invisible work. And so there became a large local interest to explore how to best capture within the medical systems a timestamp to be able to measure, monitor, and ultimately manage this. both to understand exceptionally efficient individuals, but then also to identify outliers and provide outreach and tools. So this really helped us spearhead the challenging point that I brought up earlier, which is the use of what is commonly endorsed in most contexts where Epic, which is our electronic health record, uses, which is a service they have, which is a very good service called Signal, which is able to basically earmark certain timeframes of the day and highlight whether or not it's appropriate or not appropriate, and then how much time is being spent. But the challenge with Signal, especially in academic environments, is that it has a lot of limitations. The first one is that it has a 5-second timeout, meaning if someone's in a medical record and they don't move a mouse or touch a button for 5 seconds, it says that it's no longer counting. So that time does not count within what Epic captures. So in what's called cognitive specialties, so oftentimes when there's a lot of thinking involved, not necessarily documentation heavy or procedural heavy, where someone is in the medical record quite often, it can underestimate the potential. The other thing is that what Epic tends to do is it looks at quote unquote scheduled days, which means that within a healthcare provider, there has to be a patient dedicated to see them in that specific day for it to count it as a scheduled days. Otherwise, it can count it as working outside of scheduled hours. Now, one of the challenges with that in an academic environment is that when we work with medical residents, we oftentimes don't have our own direct patients attached to us, but we're still in the medical record and we're still working as we're supposed to be. But this can overestimate what Epic is saying we are working when we should not be. And the other challenge is that when there's mixed days, so if we have a morning session but no afternoon session, the default is that Epic says we should be working the entire day, 7 to 5:30. And so if you're working the entire day, even though you only saw patients for half the day, Epic says that's perfect, that's what you should be doing, even though you're spending 1 hour outside of clinic for every hour in clinic. So there's a lot of limitations, again, period, but especially in an academic environment where, which I'll highlight a little bit later in my division, the average clinical FTE is 0.6, meaning that 40% of the time we're doing something that is not clinically relevant. So this began the hypothesis that Signal poorly captures cognitive specialties and overall time, and that overall time in the electronic health record is a better way of assessing this. And the assumption is that if we asked people to self-report, it would be considered a gold standard, that there would not be an incentive to cheat, and that people would be honest. And we wanted to really best characterize the time spent related to direct patient care activities. So not research, not quality improvement, but if something directly influenced a patient activities, either that the clinician was using PubMed or UpToDate or open evidence or some sort of tool, it still counted if it was directly related to patient care. If they were in front of a patient, it obviously counted. And if they were caring for a patient in the context of teaching, then it counted as well. However, if it was teaching from a didactic, it would not. So we defined this to make sure that physicians would self-report. And we wanted to track this with physician self-report to coincide with Epic's data pool. So what you can see on the right here are the 5 different ways. Actually, A and B are the single, but they're separated for a reason. But the 4 different ways that we measure time across a 1-month period. One was what Epic does through their Signal program, which is they measure pajama time, which is defined between 7 a.m. and 5:30 p.m., so outside of usual work hours, and on weekdays on the weekdays, and then also on the weekends. And then they also have something called non-face-to-face time, which is basically a combination of that pajama time, but then also time spent on unscheduled days. So again, no patient was scheduled for that healthcare provider or time on outside of scheduled hours. And so that's a kind of one and the same, but they define it slightly differently. And then they also have something called face-to-face time, which is basically the minutes spent charting on activities between 7 and 5:30 with a patient attributed. Again, there could be one patient scheduled at 8 a.m. and Epic would define that as a face-to-face time for the entire block of 7 to 5:30. That was collected in parallel to something called an Epic raw pool. So this is the ability for Epic to track in total aggregate system by healthcare provider over a 4-week period of time how much someone was logged into the system. This is not bound by that 5-second rule. And our hypothesis is that this was a better marker. Even though it's imperfect, it was better than signal. To be able to understand that, we did self-report. And so we asked physicians to map out daily how much time they spent related to direct patient care activities. And we used something called Clockify, which I'll talk a little bit about in a coming slide. And then we also independently audited their administrative schedules. So we went to the clinic managers and we said, give us what Dr. Smith was supposed to be doing in the month of May, whether or not Dr. Smith was working with residents, whether or not Dr. Smith had his own patient scheduled or her own patient scheduled, or whether or not they were not scheduled to see patients, so that we could compare these by time blocks. So a little bit more about the self-report. So Clockify, for those of you who are not familiar with it, this is an independent service that is able to integrate with Outlook, but it has both a URL-based login as well as an app-based login, where basically blocks of time by day of week are able to be demarcated by a specific task. This is widely used at UC San Diego Health administratively. So clinical medical directors and many clinician administrators and many administrators use this to help track different time burdens for different projects or time burdens in general. And so this tool was readily available to us and served as an independent proxy for self-report. So this is my for example, my Clockify from today, which pulls in Outlook. And what you can see is you can kind of drag and drop from that bar however long you want for a specific box and demarcate what you're specifically doing. So we defined how this should be entered within Clockify for the physicians that were enrolled for this project, so that we can map it across that Signal and Epic 4-week block. All right. So we were able to get approval through Acquire. For those of you who are not familiar, Acquire is a branch of the IRB that helps to really look at quality improvement, since the aims of this was really exploratory and it was very leadership supported. I really want to emphasize this, that this was endorsed by primary care administrative leadership, because they recognize that turnover is a very expensive and critical issue, and that burnout is a really important thing to address. And if we had a better way of monitoring and managing to create a dashboard, they were very much in tune with our incentive to better understand this as well. And so we decided to do this as a pilot for one single clinic. And so every doctor at Lewis Family or Internal Medicine was recruited and consented with the same month and same day launch, which was facilitated in May of 2023. Everyone had Clockified training before if they were not familiar with this service. And we asked them to collect information across 6 weeks to assure that we had the ability to do fidelity checks pre and post the Signal 4-week block that was collected. And then we retrospectively, as I said, audited all the managers for what doctors actually did when they were supposed to be doing it. And then we're able to work with an Epic analyst to get the Signal and the raw Epic data pools. We also collected some very basic demographics, including obviously CFTE. So this is clinical FTE, and then also years from residency, gender, and rank and step. So what academic rank and step. These data sets were then manually merged across the exact same timeframes, so that we could do as consistent monitoring as possible. An important caveat there is the raw Epic time did not have timeframes. It was just the entire 4-week period. So for the other 3, we were able to assure that 8 a.m. on a Monday, May 14th was the same across all 3 measures, that we could compare them across that and then compare it to the raw Epic time in total across the entire 4-week period. So we used our Clockify self-report to differentiate the demarcations to align with signals. So we made blocks for pajama time, before clinic hours, business hours, after lunch, and after clinic. And then we did the exact same thing for the manual clinic audits, except there, importantly, we differentiated whether or not a physician had a private practice, meaning they were seeing their own patients. They had a mixed schedule, meaning they were seeing at least one of their own patients, but also were teaching residents, or whether or not they were doing resident clinic only, so that we could help to explore some of the limitations with time outside of scheduled hours as Signal collects. From a statistical analysis, we looked at correlations, intra-class correlation across the different measures. And then we also looked at measurement bias and agreement bias with Wilcox and Rank and Bland-Altman analysis. And then we validated it by looking at the pajama time specifically for self-report to ensure fidelity across the physician self-report. We also did a very exploratory regression with our limited N to better understand drivers of time. And we did our analysis in SAS 9.4, and then we independently contracted out with ACTRI's biostatistics team, the Bird Analytics support, who used R. So a little bit of the demographics. So I don't want to get too much into the details since, of course, anonymity is important, but the N is so low that it certainly is conceptually possible to backtrack who was who. But we did have all 8, as I said, enrolled, 50% male, 50% female, 50% were clinical professors. The average person at Lewis at the time was practicing for over 10 years, and the average clinical FT at that clinic setting was 0.6. And we found no difference in men and women for the clinical practice. What's important, though, is what you can see is the average amount of self-reported time, which is shown on the bottom right there, is that there was a significant variance across the measures. The highest was self-report, and the lowest was signal, with a pretty substantial differential. I'll talk a little bit more about that in a second. So looking at these different self-reports, which again are summarized on this correlation matrix here, is that when we looked at controlling for CFTE for highest to lowest, the best correlations that existed were for signal to the epic raw. So again, epic raw is really what we were hypothesized to assume to be the best. So signal correlated best with itself because they're both coming from Epic Enterprise. But there was a 60% difference between those 90 hours against 150.9. So I think this is an important thing to keep in mind, that correlation can mean that there are data points that align in the same cluster, but they can be very different in raw numbers. So even though it was the closest correlation by Spearman's correlation coefficient, they were widely different. The next best correlation coefficient was the epic raw to self-report. So that was only a 9% difference, which you can see on the bottom there, which is the self-report of 166 hours and the signal raw of 150.9 hours. And we found no statistical correlation between schedule time and any electronic measure. Intra-class correlation coefficient, as a reminder, this is a way of basically saying across repeated measures, how aligned are those measures at capturing the same thing. And when we controlled for clinical FTE, which is basically a transgression from the bottom left to the bottom right graphic, we found that the intra-class correlation coefficient went from 0.71, so moderate, to 0.04. So extremely poor intra-class correlation coefficient controlling for clinical FTE. What this means is that these time measures, so doing it by Clockify, auditing the time, and then using Epic, they're completely measuring separate things. Within themselves, they're all measurably reliable, but they really are capturing completely independent captures of time. When we started controlling for clinical FTE, we found a couple important other things. The first one is the total average aggregate time for scheduled time was the closest to the signal clean time. So when we looked at their administrative, what they were supposed to be doing, it really aligned beautifully with the signal clean time. Now, administratively, this is exactly what they want to see. They were scheduled to see a patient for 102 hours, and Epic said that they were doing work for 90 hours. So that says to an administrator, the EHR is doing a phenomenal job because that's what doctors are supposed to be working in that specific month. But of course, that's not really the entire story, as I alluded to before. And the other thing is that the correlation between these was extremely poor. The R was 0.47, which was not significant. And this really helps to underscore how likely the true work is related to patient care. We found the Spearman correlation coefficients for self-reported time from Clockify were the most strongly correlated with the epic time, followed by the corrected signal time, and very distantly by the schedule time. So this is basically saying that schedule time is under capturing the amount of time that is being spent. And then moving on a little bit more, since I know this is really stats heavy though, is we wanted to really look now at pajama time to say, were doctors honest with their self-collection? So we looked at pajama time, which is defined as 5:30 until 7:30 p.m. On weekdays, and we found that the signal correlation coefficient between what physicians reported that they were doing and what Epic said that they were doing was 0.91, which was statistically significant. So it aligned very beautifully, which you can see the correlation matrix on the top right there. And that the interclass correlation coefficient between self-report and signal was also very good, which was 0.83, which was also statistically significant. We found by Wilcoxon a statistic that the mean difference was not different. So that's exactly what you want to find for this to basically say, are they different or are they not different? So Wilcoxon basically said that there was no difference between using self-report or Epic's Clockify, suggesting strongly that physicians were not lying. And then we use Bland-Altman plot, which is shown on the bottom right there, which for those of you who are not familiar, this is a way of schematically representing the differential between data to look for systemic bias. So if there were a systemic bias, for example, as the means increase, you would see more clustering above or below the median. And the Bland-Altman suggested no systemic bias in reporting. So this really concludes that physicians were honest with their reporting, at least using pajama time as a sensitivity analysis. So putting it all together for the results, what we found from this pilot is that with signal in the audited schedules of the time outside scheduled hours, sorry, a couple more sensitivity analysis that we did, excuse me, before we get to the final results, is that when we looked at time outside scheduled hours to look at resident clinic to schedule the teachings, we found that those who had more resident clinics, in fact, signal said that they were working outside of scheduled hours more often. Which was exactly what our hypothesis was. So this is signals basically saying that doctors weren't supposed to be working when they were supposed to be working, which again highlights the fact that this tool might not be appropriate in the academic environment. But we didn't find that it was statistically different. But there was a strong trend. So we didn't have the power to say that they were statistically not working outside of scheduled hours when they were supposed to be, but you can see the trend was quite strong with a P of 0.78. And then looking at the raw epic, the total amount of epic time, kind of our final hypothesis, is raw epic the best way? And Clockify, since we validated that doctors weren't lying, we considered it to be the gold standard. We found the intra-class correlation coefficient quite robust at 0.84, which was statistically significant, which indicated a good level of agreement. But Clockify was still higher by about 14 hours a month, which was statistically significant. So it was different, and it was higher, but the intra-class correlation was quite good. And again, by Bland-Altman, we found really no systematic bias, rather, which is shown on the bottom right there. So the final conclusions from this pilot is that even though it was limited by N, or actually really quick, is we did try to do an exploratory regression. I don't know if anyone here is familiar with doing a regression, but it was a bold ask for us to try to do this with an N of 8. But we did try to do this, and we modeled the data 3 different times to be able to get what fell out. And ultimately, even with the limited data, we were able to look at some important factors. And we found that gender was actually not associated with increased time burden, which has been shown in other literature, at least in the context that we studied. But we did find that professors were more likely to spend less time in the electronic health record when we control for clinical FTE by about 25 hours a month. So a pretty substantial difference, which has a lot of hypothesis-raising questions. But again, sorry to allude to this a couple times slides ago, but our final conclusions was that the doing these time tracking methods were measuring different things. The intra-class correlation coefficient was extremely poor, even though they were all telling the same story, highlighting the fact that different measures can be used in different contexts to tell different stories. But we found that Clockify and the raw epic most closely aligned, not just by correlation coefficient, but also by strong association with intra-class correlation coefficient. We also concluded that the scheduled hours underestimated the true workload. There was only a 54% agreement with the self-reported hours to the amount of scheduled hours, which actually aligns with outside literature that there is about 0.7 to 1 hours outside of clinical settings for every 1 hour inside clinical settings. We also found a substantial after-hours pajama time validation, which I think brings a lot of strength to being able to interpret these findings. We also find that lower academic rank in this pilot study. Again, very early conclusion to draw. In fact, it would be more hypothesis generating, but that earlier academic ranks have greater electronic health record times when controlling for clinical FTE, which is a specific target of importance because of the challenges starting up as a new physician in a new environment. So the final conclusions were that self-reported time was reliable and valid, and this was shown in the after-hours work time with a high agreement, and that the epic raw time was probably in this context the best electronic measure to continually use to be able to track the full scope of duties related to clinical cares that captures physician responsibilities. The reality, of course, is the health record is here to stay. I think it's critically important from safety, from quality, for patient care. It has a huge amount of value, but the reality is that it does contribute to burnout. And so we can't understand the best way to track outliers and whether or not there are trends that are moving in the wrong direction. We really fail to capture the true pressures that clinicians face. And so the idea is that as we shift to a new approach, is that we're strongly suggesting we really use this epic raw time instead of signal time. But this is a really limited pilot in N of 8, and so there are a lot of validity concerns monitoring 8 people across 1 month. So we don't really understand also how physician perceptions were done since it wasn't systematically captured in this pilot. And so we really don't understand when someone is particularly efficient from a timestamp, whether or not that's independently a sign of burnout, that maybe doctors are just checked out, so they're doing less and less, or is it the opposite, that doctors are burned out because they're spending too long on the electronic medical record in this context. We also don't know how it looks across other primary care settings. So right now we're in the middle of expanding this in family medicine as well as, again, in general internal medicine to enroll up to 30 doctors, ideally 15 in medicine and 15 in family medicine, and to really contextualize this more robustly to understand more comprehensive demographics and mitigation tools. For example, the use of AI interfaces, or for example, Nabla, which for those of you who are familiar is a new tool that clinicians have. But also to include formal measures of burnout and compassion, and then also to integrate questions regarding self-determination theory measures. Since we want to make sure that we understand that there is agency and autonomy for physicians to practice the way that they want to, and so self-determination theory is a really critically important piece that we feel is missing from the original pilot, for people to be able to have a voice to say, when we're tracking this time, and we're measuring monitors of burnout, does it align with self-determination? Are doctors able to have agency in the decisions that they're making, or are they feeling like they're losing that agency? So where that is right now is it's formally IRB approved, and we are about 35% into the consenting process. Had a couple barriers, enrollment, and of course the irony there, the elephant in the room is that even though there is some time incentive to recognize that this is an extra task. Nonetheless, it is an extra task that seems to occur year over year. There's just more tasks on everyone's plate, doctors inclusive of that statement, that while everyone seems to be invested in exploring this and understanding the importance, it still nonetheless is a challenge to commit to 6 weeks of tracking on another system, though we're working through many of these barriers. We're also having a couple more issues coordinating with Epic than we did the last time, though those were recently adjudicated, but that's created a little bit of a couple barriers. But the real goal, again, is to validate this, again, in different contexts and in different times, and then to understand more robustly how mitigation and other factors contribute to burnout and compassion, and then work with administrative leadership, who we have their active ear, to operationally make use of these findings if they pan out, so that we can create a dashboard to be able to monitor this with a special attention to junior faculty who are well recognized at carrying a disproportionate burden of burnout symptoms. And also, importantly, if possible, contextualize a lot of the newer sources that have been made available in the last year to see if they pan out, at least with self-report, for seemingly improving, all else equal, measures of burnout and or whether or not they potentially potentiate decreased compassion with a reliance on technology.